This talk is intended to give you a strong approach to cervical spine CT. It is intended mainly for early radiologists, but others will find it beneficial. The focus of this talk is the approach, which includes the pearls and the measurements that you're going to need to know moving forwards. There will be an emphasis on findings that you should absolutely never miss, as well as commonly missed findings to minimize the chance that you're going to miss the same things. We won't cover all the different types of fractures here, but we'll make suggestions as to which resources you should read that are the highest yield. I suggest reading the radiographics article on cervical spine trauma. In my opinion, this is a must-read for future radiologists. If you're going to do radiology, you're going to look at a lot of C-spines. If you watch this video and learn the basic fractures in the article, you'll be way ahead of the game. So let's get started. So, we'll start with a normal cervical spine CT and point out some normal anatomy and the most important measurements that you're going to need to know. As I mentioned, we won't cover all the details regarding each of the types of C-spine fractures, but we'll suggest the best places to learn this information most adequately. We will then quickly mention the big categories of cervical spine injuries and some pearls. Next, I will demonstrate a full approach to the cervical spine, similar to one you might use on call. Then, we'll apply this approach to some real cases. If you're a resident at U of T, you're going to see a lot of traumas and look at a lot of C-spines. Previous residents have mentioned that looking at spines is one of the most difficult areas, primarily because findings can be subtle and the consequences of missing something can be huge. So, practicing this full approach will be important. This is a normal C-spine CT. Let's review some basic anatomy. We'll start with the bones. This here is C1, also known as the atlas. It is split into the anterior arch and the posterior arch. These here are the lateral masses and the transverse processes. The hole in the transverse process is referred to as the transverse foramina. This is where the vertebral artery goes through. As I scroll down, this is C2. It is made up of the dens superiorly, and as I scroll inferiorly, the body. These are the pedicles. Pedicles, think feet. The feet are coming off the body, and these here are the lamina. Again, we have the transverse processes with the transverse foramina. More inferiorly, we have C3, C4, C5, C6, and C7. Vertebral bodies C3 to 7 are called the subaxial spine. Subaxial because it is below the axis, which is C2. Each are made up of a body, pedicles, lamina, transverse processes, which include the transverse foramina, and spinous processes posteriorly. On the sagittal reformat, these are the vertebral bodies. This up here is C1, this is the anterior arch and the posterior arch. This is C2 with the dens superiorly and the vertebral body portion of C2 inferiorly. These posteriorly are the spinous processes, and this is the spinal canal in the center. On coronal images, let's take a look at C1 and C2. These are the lateral masses of C1. We can scroll back to see the posterior arch and scroll more anterior to see the anterior arch. This is C2, this is the dens or odontoid process, and this is the body portion of C2. Next, we talk about the important joints in the C-spine, and you're going to look at these joints on every single CT C-spine. There are also important measurements that you need to know regarding these joints. Let's start from the top of the spine. As we go through the anatomy, we will discuss the most important craniocervical measurements. If there's one thing that I get across in this talk, it is to focus on the craniocervical junction. First, we discuss the atlanto-occipital joint. The atlanto-occipital joint is the articulation between the atlas, aka C1, and the occipital condyle superiorly. On every CT, you're going to look here to make sure that this joint is congruent. It should look nearly perfectly congruent every time. Any subtle widening above 2 millimeters should be noted, and if the joint is greater than 4 millimeters, it's diagnostic of complete dissociation of this joint. Here is the joint on coronals. These are the occipital condyles. These are the lateral masses of C1. This here is the atlanto-occipital joints. And here are the joints on axials. These are the occipital condyles. And as I scroll down, these are the lateral masses of C1. This joint here, again, is the atlanto-occipital joint. The next joint that we look at is the atlanto-axial joint, the articulation between the atlas, which is C1, and the axis, which is C2, aka the atlanto-axial joint. The atlanto-axial joint. It is made up of the median portion of the joint and the lateral portions of the joint. In the midline, there is the articulation between the dens of the odontoid process and the anterior arch of C1, and laterally, it is made up of the articulation of the lateral mass of C1 and lateral mass of C2. Again, you're going to look at these two articulations on every single CT scan. For the first one, this space here is called the pre-dens space. It should measure less than 2 millimeters in adults. Anything larger than that in an adult is abnormal. On the coronals, this is C1 and this is C2. You look at the articulation between the lateral masses, also known as the lateral atlanto-occipital joint, which sits right here. On coronal images, the lateral joint space, where my mouse is right now, should measure less than 1.2 millimeters at its narrowest point. Don't worry about the numbers for now. Just know that it should come very close laterally, and any more widening is abnormal and should be noted. There it is on the right, and there it is on the left. Note that dislocation or subluxation of the atlanto-occipital or atlanto-axial joints are referred to using an umbrella term, craniocervical dissociation. Now, there are other measurements that you can look at that will help clue you in that there may be craniocervical dissociation, and you need to know some of these. Other than looking at the joints themselves, the most sensitive of these is called the basion-dens interval, or BDI. It is measured as the distance between the tip of the dens, which is here, to the basion, which is this point right here. On CT, the distance from the tip of the dens to the basion, or the basion-dens interval, should be less than 10 millimeters normally. Any wider, and you need to suspect dissociation and look for other signs. The measurements that I've already mentioned so far are the most important for you to look at every time. I'll quickly mention one more because it is often discussed, and that's the Powers ratio. The Powers ratio is more helpful for plain X-rays and not as helpful as the ones we've discussed so far for CT. However, it is still reasonably sensitive and can be thought about and looked at when you're looking for subtle craniocervical dissociation. I mentioned that this is the basion here. This here is called the opistheon. Powers ratio is the ratio of the distance from the posterior arch of C1 in the midline to the basion over the distance from the anterior arch of C1 in the midline to the opistheon. If the ratio is over 1, it's considered abnormal. Now, to remember this, you could try to remember the formula that they provide every time that they teach you the Powers ratio, and many people do that, and to be honest, it can be confusing. But let me simplify Powers ratio for you. Powers ratio is meant to be sensitive for anterior translation of the skull compared to the spine. In other words, it is made to detect when the entire skull translates forwards. So, if you make these two measurements, and you know that the measurement is from the posterior C1 to the basion and the anterior C1 to the opistheon, if the measurement from the posterior arch of C1 to the basion is longer or larger than the other measurement, then that will detect anterior translation of the skull compared to the spine. Therefore, if this distance is bigger than that, we have a positive Powers ratio. The next set of joints we talk about are in the subaxial spine and should also be examined closely on every CT scan. These are the facet joints. You need to look at these bilaterally on every CT C-spine. Any widening of the facet joint or anterior translation at the facet joints needs to be mentioned. Lastly, we talk about the uncovertebral joints, which are right here. You generally look at the uncovertebral joints to look for subtle fractures of the uncus. The third thing we talk about are the ligaments, and we'll look at them on sagittal. The ligaments are best assessed on MRI, but you need to know the basic anatomy. Anterior to the vertebral bodies, we have the ALL, or the anterior longitudinal ligament. Posterior to the vertebral bodies, we have the PLL, or the posterior longitudinal ligament. We have the interspinous ligaments between the spinous processes and the supraspinous ligament at the edge of the spinous processes. The continuation of the ALL superiorly is called the anterior atlanto-occipital membrane. The continuation of the interspinous ligaments posteriorly is called the posterior atlanto-occipital membrane. The continuation of the PLL superiorly is called the tectorial membrane. There are two sets of ligaments that insert at the tip of the odontoid that you have to know. There is the apical ligament in the midline, which is a small fibrous band from the tip of the dens to the basion, and the alar ligaments, which are best seen on coronal. The alar ligaments are thick, horizontally directed ligaments, lateral tip of the dens to the anterior medial part of the occipital condyles. As a quick pearl, if you're going to remember any of these ligaments, it's the alar ligaments that we just discussed. The alar ligaments will come up again and again. Remember their insertion points because subtle flecks of bone here off the anterior medial portion of the occipital condyle or the superior lateral portion of the odontoid process often represent avulsion fractures. As an example, avulsion fractures from the occipital condyles are unstable and shouldn't be missed. We'll discuss these later. On axial images, posterior to the odontoid process, we have the transverse ligament. The transverse ligament is a strong horizontal ligament behind the dens that runs between the lateral masses of C1. It keeps the dens pushed up against the anterior arch of C1. Basically, it keeps that pre-dens space normal, less than 2 millimeters. Lastly, we change to soft tissue windows. On every CTC spine, you need to look at the prevertebral soft tissues on both sagittals and axials. You're looking for this fat stripe right here. Any soft tissue swelling should be noted. You're also going to look posterior to the vertebral bodies for any high density material or thickening that might indicate an epidural hematoma. It is useful to look at the soft tissues on axials as well. Looking at the prevertebral soft tissues, again looking for that stripe of fat, which is the dark tissue that you see right here, and making sure that it doesn't bulge anteriorly and there's no thickening of the tissues anterior to the vertebral bodies. You can also look in the canal as well for any high density material or thickening posterior to the vertebral bodies to suggest an epidural hematoma. So these were mentioned in the anatomy and pearl sections, but I've put them here for reference. You don't necessarily need to memorize them, but know where to look and get used to what looks normal. You can always keep these numbers accessible to you on call so that they can easily be accessed. To quickly review, the atlanto-occipital joints, if they measure more than 2 or 2.5 millimeters, that suggests that they are abnormal. If they measure more than 4 millimeters each, that's diagnostic of craniocervical dissociation. If the BDI or basion-dens interval is greater than 10 millimeters, that's a sensitive but not specific sign for craniocervical dissociation. So if you see it, you need to look at the other joints closely to look for other signs. The atlanto-dens interval, or the pre-dens space, should not be greater than 2 millimeters in adults. It's bigger in kids. It can be up to 5 millimeters in kids, but you'll be looking at mostly adults. Greater than 2 millimeters, or 2 millimeters is the number you have to keep in mind. When you're looking at the articulation between C1 and 2 laterally, there should be no more than a 1 to 2 millimeter step off laterally. Anything bigger than that is abnormal. As I mentioned, this talk is not intended to teach you all of the different types of fractures. The reason why is because there are several great resources that present this information very well. Resources include the following. There are StatDX and RAD Primer articles that include all of the raw content that you need to know with respect to the different types of injuries, but it can become very heavy and doesn't give you a simple framework to follow every time. In my opinion, the radiographics article on C-spine trauma is the highest yield resource that presents the information the most clearly. In my opinion, this is must-read information for future radiologists. Emerge Requisites is also good for a quick review, but I found the radiographics article the most helpful. It might be helpful to look at Rad Primer to learn the raw material first, and then to organize that material in your head by looking at the radiographics article. That's what I found the most helpful. What we will do is quickly mention the major categories of injuries and some key pearls. But this is in no way meant to replace reading about the different types of fractures, because we can only cover them superficially here and mention some pearls. So, first we talk about craniocervical injuries, which refers to injuries from the level of the occipital condyles down to C2. As I mentioned earlier, it's imperative that you examine the craniocervical junction carefully on every single scan that you read. The main types of injuries are as follows. First, craniocervical dissociation. As I mentioned earlier, craniocervical dissociation is an umbrella term that describes not only the complete dislocations, but also the more subtle subluxations or distraction injuries that can occur at the atlanto-occipital and atlanto-axial articulations. Again, at the atlanto-occipital, aka the junction between the atlas and the occipital condyles, aka the skull and C1, and the atlanto-axial articulations, between the atlas and the axis, between C1 and C2. We discussed some important measurements at the craniocervical junction that will help clue you in to more subtle craniocervical dissociation. If I stress one thing in this lecture, again, as I mentioned earlier, it is to never miss subtle craniocervical dissociation. We will stress this and show examples of craniocervical dissociation when we look at real cases later. Second, occipital condyle fractures. Fractures of the occipital condyles are separated into three types, types 1, 2, and 3. Type 1 refers to a comminuted fracture with little displacement. Type 2 refers to a skull-based fracture that happens to extend into the occipital condyles. And type 3 refers to avulsion fragments of the occipital condyle, which occur at the insertion of the alar ligaments. Remember, the alar ligaments span from the tip of the dens to the anterior medial occipital condyles. If you remember any of these fractures, it's the type 3 occipital condyle fracture, aka the alar avulsion fractures. These avulsions of the occipital condyle are the most unstable of the three. They are also the most subtle to pick up. You need to specifically look for subtle avulsions of the occipital condyle on every C-spine. This is an example of a type 3 occipital condyle fracture, aka an alar avulsion, on the right here. This is an example of the same fracture on the axial slices. You need to look here every time to look for subtle avulsions. Next, we talk about C1 fractures or atlas fractures. Atlas fractures can come in various forms. A Jefferson's fracture refers to a burst fracture of C1. If you have fractures through both the anterior and posterior arches of C1, you can call it a Jefferson's fracture. This is an example of a Jefferson's fracture with fractures of the anterior arch and the posterior arch. A quick pearl is to watch out for an unfused anterior or posterior arch of C1. It can mimic a fracture. This is an example of an unfused anterior arch. Specifically, you should look for well-corticated edges. Notice that the cortex or the denser bone here can be traced all the way around. C2 fractures or axis fractures also come in a variety of forms. This includes hangman's fractures, which refers to fractures of the bilateral pars or bilateral pedicles. Dens fractures or odontoid fractures can be also separated into three types, type 1, type 2, and type 3. Type 1 odontoid or dens fractures refers to avulsions at the tip of the dens from the alar ligaments. Type 2 dens fractures are fractures through the dens at the body-dens junction. This is an example of a type 2 dens fracture. And type 3 occurs when the fracture extends into the C2 vertebral body. Type 2 fractures are considered the most unstable and have the highest rate of non-union. So, if you're going to remember any of those three fractures, it's the type 2 dens fracture. Subaxial fractures refers to fractures that occur below the axis, which is C2. They are subaxial or below C2. For fractures that occur from C3 to 7, there are many different classification systems that are out there, which can make things really confusing. You'll probably read or hear about the 3-column concept of spinal fractures. You can pause this video and look it up if you haven't heard of it before. Another common way to describe these fractures is by mechanism: flexion compression, pure compression fractures, flexion distraction, extension compression, extension distraction, and lateral flexion. On top of that, there are also various eponyms such as chance fractures that are used. You can probably already see why people find it exceedingly difficult to describe and classify C-spine fractures when you first start. I do think it's important to at least be familiar with the various classification systems, terms, and mechanisms, but because there is a lot of overlap in terminology, for example, the most common cause of a chance fracture is a flexion distraction injury, and multiple mechanisms can occur in one injury, I think that relying on these terms to describe injuries can really confuse things. The radiographics article that I mentioned earlier presents the SLIC system of describing these fractures. It separates the morphology of the actual fracture itself into 4 categories from least to most severe. Simple flexion compression fractures are considered grade 1, which involves a fracture causing loss of height of the vertebral body, most often anteriorly. Burst fractures are considered grade 2, which are caused by greater vertical compression force. Often you have greater loss of height and retropulsion of fragments, and the defining feature of a burst fracture is that the fracture line extends through the posterior cortex of the vertebral body. Injuries that demonstrate distraction are considered grade 3 and are more severe. Distraction refers to a dissociation or separation in the vertical axis. Basically, the fragments separate in a vertical direction. And then lastly, we have translation injuries, which are grade 4, and that refers to vertebral body offset in the horizontal direction. Within the SLIC system, a separate comment should always be made regarding suspected ligamentous injury. The specifics are beyond this lecture, and again, I suggest reading the radiographics article for a good summary of the SLIC system. Now, if this is the first time that you've ever learned about C-spine fractures, this might all be gibberish to you. But once you've been more exposed to these types of fractures, this is going to make a lot more sense. If this is too much for now, just know that there are many classification systems out there for subaxial C-spine fractures, and the SLIC system summarized in the radiographics article makes it easy to understand and describe these fractures less variably. Very quickly, I wanted to draw your attention to certain injuries that are the most commonly missed. The hope is that when you go on to learn about all the different types of fractures, you're going to pay special attention to learning these. And when you look at C-spine CTs, you'll specifically look for these things. First, subtle craniocervical dissociation. I've harped on this already. You need to look closely at the joints of the craniocervical junction and know the basic measurements. Second, occipital condyle avulsion fractures. They can be subtle, so always look. We saw examples of this earlier. Third, extension injuries. You'll read more about these later, but for now I'll mention that they can be very subtle. Some signs of extension injury include widening of the intervertebral disc space anteriorly, narrowing of the space between the spinous processes posteriorly. If they're more severe, you can get fractures of the posterior elements, and you can get avulsion of the anterior inferior corner of the vertebral body from the ALL, also known as an extension teardrop. You need to remember to look for widening of the anterior disc space because this can be the most subtle finding in what is a severe extension injury. This is an example of a patient with an extension injury. You can see that there's widening of the vertebral disc space anteriorly, and there is narrowing of the interspinous space posteriorly. An avulsion fracture, as I mentioned, also known as an extension teardrop, would be an avulsion fracture of this corner of the vertebral body here. You can also get fractures of the posterior elements, as you can imagine, when you extend and the upper posterior elements bang against the lower posterior elements. Fourth, we talk about teardrop fractures. I just mentioned extension teardrops. Flexion teardrops can also look similar, but you need to look at the overall pattern of the entire injury at the location. Look at the location of the teardrop, and also look at the shape of the teardrop to determine which one you're looking at. Flexion teardrops are generally larger than extension teardrops. Remember, this is because extension teardrops are avulsions. You're going to get a smaller portion of the bone breaking off in extension than in flexion. The extension teardrop most commonly occurs at C2. This is an example of an extension teardrop at C2. A flexion teardrop most commonly is seen lower down, most commonly at C5-6. This is an example of a flexion teardrop fracture. Notice how it's bigger, it's at a different location, and the pattern of injury is different. As you can see, this is a flexion pattern of injury with distraction posteriorly. Lastly, you need to look for subtle distraction of the facet joints. Any widening of facet joints should be mentioned. Again, don't memorize this list. This is here for your reference and to clue you in to some subtle findings that are often missed. Another pearl is knowing mimics of fractures. First, non-fusion. We mentioned this before and showed a picture earlier of non-fusion of the C1 rings. Look for a sclerotic border to know that this is not an acute fracture. While I'm talking about non-fusion, I should also mention the fracture mimics at C2, which include a parent non-fusion of C2 called os odontoideum. You should look up os odontoideum, look at images, and be able to differentiate it from os terminale, which occurs more distally at the tip of the dens, and be able to differentiate those from acute fractures. Second, you'll see it very commonly, is a Schmorl's node. A Schmorl's node refers to herniation of disc material through the end plate of the vertebral body, causing a nodular defect in the end plate. This is an example of a Schmorl's node. As I mentioned, you have herniation of the disc into the vertebral body and a sclerotic border around it. These examples are more typical of Schmorl's nodes, but they can also be bigger in the anterior-posterior direction, and as a result, if you can imagine, superiorly or inferiorly, they can mimic end plate fractures. Third, we talk about a limbus vertebra. A limbus vertebra is related to Schmorl's nodes. This here is a limbus vertebra. Again, there is herniation of disc material through the vertebral body end plate, but this time it extends through usually the corner of the vertebral body. Most often it's the anterior superior corner, but can also be the anterior inferior corner. As a result, you get a fragment of bone at the corner here or the corner here, and to the untrained eye, it can look like a simple flexion compression fracture, like this one would mimic here, or if it's at the anterior inferior corner, it can mimic a teardrop fracture. The key to differentiating these is the location, the regularity of the bone, and also the sclerotic borders. Again, if this is too much information for you, for now, focus on the approach. All of these things will come up when you read about C-spine and look at more C-spines. For now, just having heard these names puts you way, way, way ahead of the game. The last thing that I want to touch on before we get into an approach and then applying it to some cases are the findings that you should look for that put a patient at higher risk for vascular injury. Many of these are C-spine findings, and when you see these findings, you need to suggest getting a CTA to the trauma team to rule out a vascular injury. There are a bunch of indications, and some of them are softer than others, but these are the most important ones that you need to know. If you have any fracture to C1 to 3, you should suggest getting a CTA. If you have fractures of any of vertebral bodies 1 to 6 that extend through the transverse foramina, you need to get a CTA to rule out vertebral artery injury. If you have any facet subluxation or dislocation, or any severe subluxation or dislocation, you need to get a CTA. Any skull-base fracture that extends into carotid canal should also prompt a CTA. There are other indications as well, things like severe facial fractures, like Lefort fractures and severe mandibular fractures, but those ones aren't as important as the other ones I've bolded and starred on this slide. Note that the approach that we're going to show is for illustrative purposes, to show you all of the things that you need to look at on all of the different planes. We will do a lot of switching through axials, sagittal, and coronal reformats. When you become more efficient and do some call, you'll still look at all of these things that we're going to discuss, but you won't have to move around as much between the reformats. So, I start on sagittal. Step 1 is a general overview. I take a look at the whole spine very quickly to see if I see anything big. Step 2, I evaluate the craniocervical junction very closely. The first part of that is looking specifically for craniocervical dissociation. So I evaluate the atlanto-occipital joints bilaterally. Any step off, any abnormality, subluxation, any widening, I need to comment on it. I then look at the basion-dens interval, or BDI, which is a sensitive sign of craniocervical dissociation. It's this distance here, and it's normal. I then look at the articulation between C1 and C2. First, in the midline, we have the pre-dens space here, which should be less than 2 millimeters, and it is. And then I look at the articulation between the lateral masses of C1 and C2, which are normal here. It's best assessed on coronals. And you can see that the lateral portion of the joint should come in close articulation, less than 1 or 1.2 millimeters. And those are normal. There should also be no step off at the lateral portion of the joint. And as you can see, normally the middle portion here can be a little bit wider. If you're measuring it, anything greater than 4 millimeters is abnormal. And then I look at the craniocervical junction in detail on all planes here. I look at C1 anteriorly and posteriorly and join them all up on the sagittals. I look at C2 closely here. On the coronal images, I want to specifically look again at the same joints that I just mentioned, looking specifically at the anterior medial portion of the occipital condyles for occipital condyle avulsions. I want to look at the dens closely on the coronals, looking for any subtle fractures here. When I look at the axials, I do the same thing. So I scroll down and I'm looking again at the occipital condyles for any subtle avulsion fractures or fractures of the occipital condyles. I look at that joint again as I'm going down. That's the atlanto-occipital joint, or the articulation between the occipital condyles and C1 lateral masses. I scroll down and I complete the entire C1 vertebral body. And then I scroll down and look at the dens and complete the entire C2 vertebral body. Next, I look on sagittals for the alignment of the C-spine. So I'm looking at the anterior and posterior vertebral lines. I'm looking at the spinal laminar line, and at the back, the interspinous line. The alignment is normal here. The next step is to look for any other injuries in the subaxial spine. First, look at all the vertebral bodies, scrolling back and forth, looking for any fractures or loss of height. After you look at the vertebral bodies, you also want to look at the disc spaces to see if they're widened anteriorly or posteriorly. Then I look at all the facet joints laterally, making sure that they all line up and there's no widening of any of these joints. These are all normal. Look at them on the other side. I can also look for fractures of any of the bones here. And then I look at the spinous processes posteriorly. Once I've looked at all the bones on sagittals, I do checkpoints again. On coronals, we mentioned the checkpoints being the craniocervical junction. I also look at the vertebral bodies on coronals. Specifically, it's very easy to miss subtle fractures near the uncovertebral joints on other planes. So I specifically look at the uncovertebral joints on coronal images. You can also assess the facet joints as well here. And then I go down the axials. I've already done it for C1 and C2, but I scroll down, and one vertebral body at a time, I look at all the articulations, completing the rings, completing the transverse foramina, and making sure I don't see any fractures. Okay, and these are all normal. If you don't like completing each one at a time, some people like looking at one element and scrolling through. For example, if you're looking at the spinous processes, you can look at that one and keep scrolling through and look at all the spinous processes at once and do multiple passes of the C-spine on axials to make sure that you don't miss anything. The most important thing to look at on axials are the transverse foramina. It's easy to miss these fractures on other planes, and they are important fractures to not miss. Next, you need to look at the soft tissues. Specifically, first you look for prevertebral soft tissue thickening on the sagittals. You look posteriorly. You look posterior to the vertebral bodies for any thickening of tissues or high density material to suggest an epidural hematoma. It's also very helpful, as I mentioned before, to look at these on axials. Again, looking for prevertebral soft tissue thickening and looking at the spinal canal centrally for any signs of epidural hematoma. Lastly, you want to look for miscellaneous things that aren't part of the spine that are on this film. For example, you want to look at the visualized brain. I've seen cases before where there's blood in the fourth ventricle and it's just a C-spine CT. You need to look at the brain to make sure you don't miss anything big. You need to look at the skull base, as we would normally look at a head CT skull base on bone windows. Look at the visualized portions of the mandible, look at the pterygoid plates, etc. Things that are often missed in traumas are fractures of the hyoid bone, which is here. Make sure you assess the hyoid bone, the thyroid cartilages for subtle fractures, and the cricoid cartilage here. Back on soft tissues, you can assess and have a quick pass of the neck, making sure that the airway is patent and looking for anything big. We'll talk about this more when we talk about neck CT. Lastly, if the chest isn't reported separately, you need to look at the clavicles and then the lungs. I've seen several cases where the C-spine is normal, but you see a pneumothorax when you look at the apices of the lungs. Okay, so this is the first case. It's a trauma. Let's go through our full approach. There are a lot of injuries in this case, so we'll just talk about the most important ones and go through our approach. So first, do a general overview on sagittals, and we already see that there's a lot of things going on here, but now we need to break it down. Okay? First, we want to rule out craniocervical dissociation. So after the general overview, we want to specifically look closely at the craniocervical junction. First, we look at the atlanto-occipital articulations, and they are generally congruent here, but it might be a little bit widened at the posterior aspect. Next, as we mentioned, we look at the basion-dens interval, which measures about 12 millimeters, which is too much. The reason why I measured down to here is that this is an osteophyte here, so the tip of the dens is actually considered this point here in this case. This is too big. So it's a sensitive sign. We need to look closer at all the joints. Next, we look at the pre-dens space, or the articulation in the midline between C1 and 2. It's okay inferiorly, but it's too wide superiorly. This V shape can be seen in normal situations, but it can also indicate transverse ligament laxity. Remember that the transverse ligament holds the dens up against the anterior process of C1. Now we want to look at the lateral articulations. We can look at them on sagittals, but they're best assessed on coronals. So looking at the articulation between C1 and C2, we notice that laterally these are way too wide. That's not normal. We mentioned that the lateral portion of C1 here should come very close to C2, and there should be no step off. There's not much step off here, but this is way too wide. There is distraction at the C1-2 articulations bilaterally here. This is diagnostic of craniocervical dissociation. Remember, craniocervical dissociation is an umbrella term to describe dissociation of the atlanto-occipital joint or the atlanto-axial joint. And we have dissociation here of the atlanto-axial joint. While we're here, we look for other craniocervical junction injuries, looking for subtle avulsion fractures of the occipital condyles, which we don't see here, evaluating the dens, which is normal here, and then looking on axials for specific craniocervical junction injuries. Again, looking at the anterior medial portions of the occipital condyles here, looking at the C1 and connecting it. In all locations, there's no C1 fracture. And looking at C2. Now that we've looked at the craniocervical junction in detail, we need to look at the alignment of the spine. So as we look at the alignment of the C-spine, we notice that there is a change in alignment, and we go from inferior to superior at this level right here. So we already know something's up, and that should clue us in to look at this location in more detail. We look at the vertebral body heights and point out any fractures. There are multiple fractures here again. The exercise is to not identify them all here, but just to know to go through your whole approach to look for different types of fractures. So this here is C2, 3, 4, 5. This is C6 here. C6 is malaligned with C7. There's a little bit of widening of space posteriorly. And if we look at the facet joints bilaterally, they're severely widened. Remember, any widening should be called. This is not subtle. There is distraction of the facet joint here on the right, as well as even more severely on the left. This is an unusual case. There's distraction at the craniocervical junction, as we showed earlier, as well as lower down in the spine. That's rare, but this is a case of it. Next, you go through your checkpoints, which involve looking at all of the bones again that you've looked on sagittal, on coronals, specifically looking at the vertebral bodies and the uncovertebral joints. Then you want to go through your axials, starting at the top and going line by line looking for fractures. So once we've looked at all of the bones on all three planes and called out all the fractures, again, there was too many to name on that one, so I don't want to waste time by going through it all for now to emphasize the approach. But then we have to look at the soft tissues. So anteriorly here, the soft tissues are severely thickened. And then you need to look for an epidural collection. These tissues are too thick, and there's actually air within the epidural space anteriorly as well, so we know that there's something going on in the epidural space. To drive home the point, we also want to look at the axials. You can look at the prevertebral soft tissues, which you can see are thickened more inferiorly here especially, with air and fluid, and this is the fat stripe that should be hugging the anterior vertebral body, but it's not. And then looking at the central canal, you see all of the air in the canal. You see the thickening of the tissues anteriorly here, especially at this level. Large collection that is an epidural hematoma. Then you look at everything else, and we won't go through that all right now to save some time. This is case 2. It's another trauma, and this will illustrate the importance of going through a systematic approach. So if we were to just quickly look through the spine and take a general overview, you might think it looks pretty normal. All the bones look pretty intact. The facet joints are all right. And you might think, oh, there's not much big there. But you need to go through your full systematic approach. So after that general overview, we need to start by looking at the craniocervical junction in detail. The reason why I always put this first is because the findings can be subtle, and missing craniocervical dissociation is not good. So if we start, we look at the atlanto-occipital joints, and right away, the atlanto-occipital joints are not normal. You might think that they're pretty much congruent, but they're not. Any step off, any widening is abnormal. This distance is abnormal. We can measure it. It's over 4 millimeters, which is said as diagnostic of craniocervical dissociation. On the other side, we also have widening. It's also greater than 4 millimeters. Let's look at the other signs. Next, we want to look at the BDI, or basion-dens interval. If we measure that, it's sensitive. It's above 10 millimeters, which is too big. The pre-dens space is not significantly widened, but again, we have that V-like formation. If a spine is normal otherwise, the V-like formation here is often not as significant. You can see that normally when you just have laxity of the transverse ligament, but no actual acute fractures or ligamentous injury. Next, you look at the C1-2 articulation on sagittals, and then we go to coronals. We then look at the lateral C1-2 articulations, or lateral atlanto-axial joints, which are normal here. Remember on the coronals to go through other checkpoints at the craniocervical junction. We want to look at the atlanto-occipital joints again, and you can see that they're wide, okay, as we already saw in the sagittals. Next to the craniocervical junction, you want to look at the occipital condyles closely, and you'll notice, this is very subtle, but there's a fleck of bone here that may represent a small avulsion fracture of the occipital condyle. Usually, real ones are obvious. This is questionable, but if you see something there, you have to raise it. Then we go to the axials, and we look at the same bones. So you'll notice, if we look at the occipital condyles again, there's no fracture through them. Notice that fragment again, anterior inferior / anterior medially. You see that little fragment, it could represent a little avulsion. Also notice on axials, even without the other planes, you can see that the atlanto-occipital joints are incongruent. We look at C1 closely, we don't see any fractures there, and we look at C2. We didn't see any fractures on the other reformats, and we want to complete all the rings, including the transverse foramina here. Remember, any fractures of C1 to 3, you're going to need a CTA. Any fractures to the transverse foramina, C1 to 6, you're going to need a CTA. Okay, so after we've evaluated the craniocervical junction adequately, we move on to looking at the alignment, and then for subaxial spine fractures, then we look at the soft tissues, etc., etc. You can go back and look at the full approach again earlier in the video, but I'll save us some time here. The rest of this case was normal. So this was a case of more subtle craniocervical dissociation. It really stresses going through your full approach and looking at the craniocervical junction in detail to see more subtle, severe injuries. Alright guys, take home points. As I mentioned before, don't worry about all the details for now. These are the most important things that you should take away. First, never miss craniocervical dissociation. In other words, you need to evaluate the articulations of the atlanto-occipital and atlanto-axial joints, and you need to know the measurements that we mentioned at the beginning. You're going to look at these every time. I'll put in the point here to also not miss other subtle injuries at the craniocervical junction, such as avulsion fractures of the occipital condyles. Second, it's cliche because it's true, you need a systematic approach. I provided an example. You can take what you like, discard what you don't, make your own. As long as you're looking at all the key things every time, you'll be fine. Third, don't just look at the bones of the C-spine. Before you finish looking at the study, make sure you look at the soft tissues for prevertebral swelling or epidural hematoma, and then make sure you look for incidentals. The hyoid bone, the thyroid cartilage, the cricoid cartilage. Look at all the soft tissues, look at the brain if it's not reported separately, and look at whatever you can of the lungs. Lastly, and I've mentioned it about 1,000 times, but check out that radiographic C-spine trauma article. It's helpful on its own, but I found it especially helpful once I was already familiar with all the different mechanisms of trauma through either rad primer articles or whatever other resource you want to use, and then put it all together with that radiographic C-spine article. Alright guys, that does it for this one. I hope it helped, and I hope to see you guys soon.